Welcome back to the Mission Brain podcast. I'm Zira.
I am Carla, and today's brief technical update will review three areas that are actively reshaping neurovascular neurosurgery: next generation flow diverting technology, the discovery of somatic mutations in vascular malformations, and the evolving paradigm to ultra early stroke intervention.
These developments are not just incremental improvements, they reflect a shift in how we understand cerebral vascular pathology and how we design interventions in both high resource and resource limited settings. But first, what is neurovascular neurosurgery?
It includes the evaluation and treatment of pathologies affecting the intracranial and spinal vasculature. Disorders including aneurysmal, subarachnoid hemorrhage, ischemic stroke, intracranial hemorrhage, arteriovenous shunting lesions, and carotid pathology require rapid diagnosis, coordinated multidisciplinary care, and often specialized surgical techniques.
Last week, I had the opportunity to participate in the Mission Brain Humanitas tutoring mission, which offered 2 full days of neurovascular neurosurgery training. Each morning featured lectures on fascinating topics such as capsule, giving us valuable clinical and scientific insights. In the afternoon, we moved on to hands-on practice, where we were able to develop essential neurosurgical skills. The workshops I enjoyed the most were the anastomosis suturing sessions, both end-to-end and end-to-side techniques, and the Dura-Mater suturing workshop. This Mission Brain event, organized by Mission Brain Humanitas and sponsored by Upsurgeon, provided medical students with an exceptional opportunity to gain practical experience using high-quality surgical simulation models. It was truly an inspiring and enriching experience.
Going back to our introduction, the first topic, next generation flow diverting technology, concerns the rapid evolution of flow diverters. Over the past decade, flow diversion has transitioned from a niche technique for selected internal carotid artery aneurysms to a frontline treatment for a wide variety of complex, wide-necked, fusiform, and even distal aneurysms. What is driving this expansion is the emergence of new generation devices such as the Pipeline Shield and the Silk Vista Baby. These devices incorporate surface modified alloys that reduce thrombogenicity and improve endothelialization across the aneurysm neck.
In practical surgical terms, this means more reliable new intimal formation, a reduction in periprocedural thromboembolic complications, and the ability to treat aneurysms in distal portary segments previously considered inaccessible for flow diversion. The implications extend beyond high-income centers. Low-profile deliverability makes it possible to standardize techniques in environments where catheter navigation is more challenging. And shorter dual antiplatelet regimens enabled by surface modification may eventually simplify perioperative protocols in global neurosurgical settings. The field is approaching a point where endoluminal reconstruction becomes the default strategy for a large subset of aneurysms, shifting open microsurgical clipping towards selecting lesions requiring direct surgical exposure.
The second advance is molecular. The identification of somatic mutations driving arteriovenous malformations and cavernous malformations. For decades, these lesions were described poorly in hemodynamic or structural terms. However, recent genomic analyses have revealed that a significant proportion of sporadic AVMs harbor activating mutations in the RAS-MAPK pathway, particularly in KRAS and BRAF and MAP2K1. Similarly, cavernous malformations, long associated with familial CCM gene mutations, are now understood to often process a two-hit somatic mechanism, even in sporadic cases, with endothelial cells-restricted mutations altering junctional integrity and vascular permeability.
These insights fundamentally change our conceptual framework. AVMs can now be viewed not only as high-flow structural anomalies, but also as clonal endothelial proliferations with dysregulated signaling. For neurosurgeons, the practical relevance is twofold. First, molecular profiling offers new prognostic markers. AVMs with KRAS mutations may demonstrate specific angioarchitectural patterns, hemorrhage risk profiles, or responses to radiosurgery. Second, the molecular pathway immediately suggests targeted therapies. Experimental work using MEK inhibitors has already shown partial normalization of abnormal vasculature in preclinical models. Although not yet a clinical standard, the possibility of adjuvant or even primary medical therapy for selected malformations is becoming realistic. This shift mirrors what happened in neuro-oncology. Once molecular drivers are identified, surgical decision-making becomes more personalized, integrating genomic information with geographic and clinical data.
The third topic is the transformation of acute stroke management. Particularly for large vessel occlusions, mechanical thrombectomy is no longer confined to patients presenting within a narrow time window. Instead, perfusion imaging and collateral assessment define the new criteria. The focus has moved from a rigid time on onset paradigm to a tissue viability program, expanding the treatment to a population significantly. Another major development is the refining of thrombectomy devices and techniques. Recent catheter technology allows higher aspiration to flow rates, more efficient clot ingestion, and enhanced first pass recanalization. Combined techniques, aspiration plus stent retrievers, have become more standardized, and the evidence is clear that rapid, effective revascularization correlates with substantial improvements in functional recovery.
What is especially relevant for global neurosurgery is the parallel rise of mobile stroke units. Automated triage systems using artificial intelligence and simplified thrombectomy workflows. These innovations aim to reduce pre-hospital delays, which remain the main determinant of outcome in low-resource settings. At the same time, the field is investigating interventions of medium vessel occlusions, and even for patients with low NIHSS but high-risk imaging features. For neurosurgeons, these developments blur traditional boundaries between endovascular neurosurgery, neurology, and emergency care, reinforcing a collaborative acute care model. As the indications broaden, comprehensive stroke capability becomes a central component of modern neurosurgical practice.
Taken together, these three areas illustrate the trajectory of neurovascular neurosurgery today. Endoluminal reconstruction replacing open air, vascular malformations reframed as molecular diseases, and stroke intervention increasingly driven by physiology rather than the clock. Each advance requires not only technical proficiency, but also system-level adaptation, especially from institutions working in underserved regions, something deeply aligned with the mission brain foundations. Improving access to flow diversion, integrating molecular diagnostics, and optimizing stroke pathways are goals that can have immediate impact for communities with the highest burden of cerebrovascular disease.
And that's it. Thank you for joining us for this brief overview of contemporary neurovascular developments. Stay with us for our upcoming interviews from our Mission Brain podcast team.